Good afternoon. I would like to sincerely thank you for the invitation to be here, not only for the opportunity to present, but also to learn from people I truly admire during these 2 days. I will talk about implementation in practice, Latin America experience. Let me start by introducing myself to give you some context for my presentation. My name is Marilia Bordignon. I am an infectious disease physician, and I completed my fellowship back in 2018. A few years ago, I started developing an interest in geriatrics. Today, I'm pursuing a PhD at the University of São Paulo in Brazil, also known as USP, where I also did my fellowship program. My research focuses on aging in people living with HIV. And along the way, I realized that my background as an infectious disease physician wasn't enough to fully address this topic. That's why I also enrolled in a postgraduate certificate in geriatric medicine. Although I'm here representing Latin America, I would like to point out that my experience may not fully reflect the diversity of the region. Even though São Paulo is the largest city in Latin America, with around 12 million inhabitants and probably one of the best resourced centers in Brazil, it still represents only one reality with a lot of disparities. São Paulo is a reality marked by strong social contracts, as we can observe in this image. My own reality includes a connection with the largest university in Latin America, which provides important opportunities for meaningful action. So what motivated me to get closer to geriatrics? Even though we, as infectious disease physicians, were attentive and sensitive to this population, some aspects of aging were not being properly addressed. Aging was often seen only as the sum of many complex conditions. Since the population in Latin America is also aging, I realized that a more holistic view of older adults was rarely applied to people with HIV. As infectious disease specialists, we are the main reference physicians for these patients. We are already at the forefront as their primary care providers, and it makes sense that we should also be able to respond to their needs throughout the aging process. Considering that care for older adults involves a different level of complexity, identifying and developing a tool that can provide information about the overall health in just 10 minutes is extremely valuable. The goal is to optimize and conduct a holistic and rapid assessment. In this context, Marlon Alibarti, which is a geriatrician from the Department of Geriatrics at the University of São Paulo, developed and validated a tool called 10-minute targeted geriatric assessment, or TENTAGA. This instrument is based on a comprehensive geriatric evaluation that incorporates 10 clinical domains, providing a measure of overall health that is highly correlated with other commonly frailty assessment. And what about our reality among HIV and aging in Latin America? The most important data we have on this topic actually comes from the CASANET group. CASANET stands for the Caribbean, Central, and South American Network for HIV Epidemiology. It's a consortium of HIV healthcare centers across 7 different countries. The curves are predictions from logistic models adjusted by year and site. We can see that the percentage of HIV patients above 50 years old increased from 80% in 2000 to 24% in 2015, probably explained by the increasing survival and retention in care of all patients. And what is my reality today? At the outpatient clinic where I work, called SEAP, which is part of the University of São Paulo, we currently follow about 3,500 patients. Around half of them are over 60 years old, and about 90% have undetectable viral load. These numbers are very similar to what we see in some places worldwide. The fact is, most of the patients we are managing today are already older adults. In our clinic, we have only a few specialties available to share the care of people living with HIV. We do work alongside some professionals from other areas. However, in practice, the management of most clinical conditions for people with HIV falls almost entirely of infectious disease specialists. The specialized care service usually have only ID physicians with no real possibility to integrate care with other specialties. Once again, as ID physicians, we assume the responsibility for ensuring the comprehensive management of older people living with HIV. And how are the clinics organized? Very few places actually have a specific clinic dedicated to older adults with HIV. Where they do exist, the criteria are usually based only on age without using tools like frailty screening. Although clinical visits allow for long appointments, very few specific geriatric assessments interventions are offered. And until very recently, specialized care initiatives depend exclusively on individual initiatives without the support of a national health policy. And the initiative to go deeper into geriatrics was not mine alone. It has been personal efforts that brought some change and structure organization to clinics caring for people with HIV. Two other pioneer women, each leading a different service, were also an inspiration to me, Roberta Schiavon at CRT and Gisele Gossuelo at Unifesp. But some changes have started to take place, helping to bring infectious disease and geriatrics close together. I would like to share a little about each of the topics below. First, the public health system already has an organization for the care for general population of older adults. The National Health Policy for Older Adults established comprehensive care for the elderly as its main goal and considers functionality as an important health indicator for this population. It prioritized the assessment of functional capacity as a strategy to identify the health needs of older adults and the resources available in each territory, aiming to structure comprehensive care. In the city of São Paulo, everyone over 60 years old in primary care goes through a multidimensional assessment of older person called MPAB. This tool assesses global impairment and helps stratify and guide care. Patients identified as individuals at high risk for adverse outcomes are then referred to a geriatrician when available. The MPAB was developed and first implemented in the city of São Paulo back in 2015 by Dr. Sérgio Pascoal, a geriatrician from the Department of Geriatrics at the University of São Paulo. The main purpose of the MPAB was to standardize the evaluation of older adults at primary care units throughout the city of São Paulo. Over time, the MPAB has also become a metric used across healthcare units. A second important change is the new initiative from the Ministry of Health to include, for the first time, a section on aging in the official HIV clinical care guideline. In Brazil, we have had national guidelines for the management, treatment, and care of people living with HIV since 1996. We call it PCDT, which is Clinical Protocols and Therapeutic Guideline. That was the year when triple therapy became available and began to be distributed universally through our public health system supported by a national law. So this manual will now also address broader health needs. It includes management of multimorbidity, but also for the first time a chapter on care of older people with HIV, written by me and Roberta Schiavon. In this section, we used the MPAB model, which was already available for older adults in primary care, as a tool for screening and stratification. With this approach, we could identify people living with HIV who are at higher risk of age-related outcomes and therefore would require more specialized care. We based our work on both geriatric and European recommendations. All because the MPAB provides not only an overall score at the end of its 17 questions, but also information for each specific health domain, we were able to make more targeted recommendations whenever alterations were detected in any domain. For example, in these two domains, cognition and mood, the initial questions are broad and general. If they come out positive, the next step is to move forward with a more structured screening. In this context, we use both the 10CS, which is the 10-point cognitive screener, and the geriatric depression scale. We also provide a document with all these tests complied for easy access, including the cutoff values to guide treatment decisions or refer to specialists. And what about other countries in Latin America? What are the current recommendations there? Identified places with published guidelines, but none of them specifically address aging. The third point related to recent changes is that at USP, all ID fellows now spend 1 month evaluating geriatric patients and discussing scientific papers, many of them written by some of you here today. Since specialized clinics will remain a minority, at least for now, it's crucial that ID physicians themselves develop a perspective on aging. Fourth point to highlight is that research initiative is essential in this field, especially in developing countries. Right now, both CEAP and CRT are part of ELEA study, which is the longitudinal study on HIV and aging. One of its aims, aligned with my PhD project, is to validate a short geriatric scale called TENTAGA, developed by Marlon Aliberti, showed in the beginning of my presentation. This work was presented at CROI this year and will soon be published. He is part of the LEA Brazil team, including the principal investigators involved. Now, you might ask me, why look for another tool if we already have the AMP-AB available as a model for people who are not living with HIV? The TENTAGA actually brings more detailed assessment. It incorporates both geriatric depression scale and the 10 cognitive screener, which are exactly the tests we would recommend if someone had a positive response in the AMP-AB, as I showed earlier. In addition, TENTAGA also includes gait speed, providing a more precise evaluation of physical capacity. And all of this can be done in just 10 minutes. It can also be carried out by any trained health professional. Finally, this interesting in HIV geriatrics interface works both ways. I first discovered the geriatrics postgraduate program I'm currently in when I was invited to lecture about HIV and aging. In this program, we also discuss sexuality in older adults and specific health issues for LGBT elders. Some papers have already been published about this topic. And how do I see the next steps? I believe that engaging in other initiatives to strengthen the field and learn from peers is extremely important, especially when we think about the disparities we see even within the city of São Paulo. This interaction here in the workshop is also a great opportunity to better understand the implementation process. As part of my PhD, one of the main goals will be to structure the clinical care pathway as a research protocol, so that information can be collected regularly and systematically, building a cohort on HIV and aging. I plan to apply frailty screening using the TENTAGA to stratify patients and identify those who require more specific care. Of course, patients identified as frail will undergo multidisciplinary follow-up, and in my service, this already includes collaboration with physical educator and nutritionists. In addition, I want to involve geriatrics fellows to help create a strong service, ensuring exchange and learning in both directions. And finally, I plan to develop models of care, especially using flowcharts for the most prevalent geriatric syndromes, making these tools easily accessible to all physicians in the service. Once again, thank you very much.
Yeah.